Okay, I think we can go ahead and get started with 10:05, and if more people show up, that's great. So good morning, everyone. Welcome to our session, and thank you for joining us today. My name is Taylor Moore, and I am an information coordinator at the Center for Effective Practice. I was part of the team that developed the newly launched social prescribing resource that we will be focusing on today. We will be highlighting two themes from our tool. The conversation to assess and understand, and follow up and follow through. We are joined today by two members of our topic expert group who will be sharing some reflections with us about their experiences with these aspects of social prescribing. I would also like to highlight that there will be an opportunity later in the session for audience participation during a Q&A period before we end with some concluding thoughts. I'd like to start our session with a land acknowledgement. The Center for Effective Practice recognizes that our work occurs on traditional Indigenous territories across Ontario. We honor the land and the people who have cared for these territories and who continue to contribute to the strength of communities across the province. The CEP would like to acknowledge that our Central Toronto office is located on the traditional territory of many nations, including the Haudenosaunee, Anishinaabe, Mississaugas of the Credit First Nation, Mississauga and Wendat peoples, and is now the home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that this territory is covered by Treaty 13. We are grateful to have the opportunity to work on this land. So I have already introduced myself, so I will pass it over to my colleague Ellen to lead the rest of the introductions.
Thank you, Taylor, and good morning. I'm Ellen Tolchinsky, and I'm a manager on the information services team along with Taylor. And I'd like to pass it over to our panelists now. Allison, if you'd like to go ahead.
Good morning, everyone, and thank you for being here with us. My name's Allison Hewitt, and I'm a geriatric specialized nurse. I work at a community health center in inner city Ottawa, Centertown Community Health Center. And my role is basically to do geriatric outreach for clients over the age of 65 who wish to stay home. So as you can imagine, with this sort of population, there is a large emphasis on quality of life, and that is, in effect, how I got into social prescribing. So I'd like to pass the baton over to Mike Creek to do his introduction.
Thank you, Allison. Hi, everyone. I'm Mike Creek, and I'm a person with lived experience. We all have lived experiences, but mine involved living in poverty and homelessness, and also some health complications along the way. So I've spent about 20 years now working within the healthcare system, trying to make changes that will have impact on communities that have often been left behind because of the structures of systems that we have in place. I work for an organization called Working for Change, which provides employment opportunities for people with mental health and substance use. And I'm happy to be here today as a representative of the people with lived experience who are part of the panel. Thanks.
Great, thank you all so much for those introductions. So the social prescribing resource was designed for health professionals like yourselves to provide guidance in implementing social prescribing in your practice. It takes into consideration that not all primary care practices have the same capacity and resources, and it aims to provide guidance that applies to all situations throughout Ontario. Once the foundation is established, implementing social prescribing with individuals typically begins with a conversation. To assist with this phase, our tool focuses on ensuring the creation of a safe space for all, leading with empathy, and emphasizing that trust and openness is the foundation to building the relationships that are necessary for successful social prescribing. We also acknowledge that setting the stage with the individual is incredibly important by clarifying your intent and describing why social prescribing might be beneficial for their health. Our tool provides talking points to help guide these conversations. These points were developed with the members of our topic expert group, as well as people with lived experience, to create welcoming language to assess and understand an individual's social story. We also recognize that some clinicians may be more comfortable utilizing screening tools, so we have incorporated a list of links to examples that may aid in the assessment of an individual's social needs and help begin that conversation to continue understanding their social stories. So at this time, I would like to pass it over to Mike and Allison to share some reflections with us, and I will start with a question for you both. What aspects of a social prescribing conversation have you found to be the most valuable, and why?
Want me to start, Allison?
Sure, you can get the ball rolling, Mike.
Okay, so I think it's for me it was building the bridge to have an open dialogue and finding ways that are healthy and safe, so that people can have a better understanding of the impacts that the social determinants have on their health. For many, those are things that people live with on a daily basis, but they don't recognize often what's happening underneath the surface physiologically to their health. And so starting a conversation with them is really important, because primary care and those that are in the healthcare system who are looking after folks, they understand this, and being able to explain to us the importance of sharing the social context that people are living in and making that a safe place is extremely critical for optimal health outcomes and for social outcomes.
I love that, Mike. And I entirely agree. Being able to do social prescribing comes from a place of meeting where the client is at, effectively holding space to hear, what's going well for them, but also what's difficult and challenging. In my practice, I'm fortunate to get to visit people where they live. I get to meet their neighbors, and a lot of things can be picked up just by doing home visits, versus it is more challenging in an office setting. You don't have quite as many cues to what might be happening or what might be challenging for your client. So making the space to have that conversation, giving them permission, to expose that there might be some really hard things going on for them is definitely key and important. And then something we think about a lot at Centertown is having sort of low barrier access. So at our center, social prescribing happens in a variety of ways, through medical providers, through community health workers, through dietitians, so I guess, and then everyone can kind of get on the same page about it. The client doesn't need to retell the story 100 different times, because it's charted in our electric medical record. Anyway, I'll pass it back to you, Mike, because I might be going on a tangent.
No, they're all really, really great points, and it can be difficult conversation, especially if you don't have a robust team behind you, or you're doing this for the very first time. it can seem quite challenging and awkward, and from a patient or person's perspective, they feel the same sort of awkwardness around having that conversation the first time. And so it's important, to be, I think, follow some of the screening tools, have a look through there, find out what fits you the best to be able to carry out that conversation and be comfortable with it, because you being comfortable with it will end up making it easier for the person that you are talking to be able to feel that comfort. And I think that comes across often very easily for building a therapeutic relationship, which is a critical in finding out what's really going on with people and how it's impacting them socially, and what are the connections that is impacting their health on a daily basis because of what you are learning about either their living conditions or some of the social challenges that they may be facing in their life right now. To me, it's always a bit like when you have to first talk to your doctor about mental health, or you feel a bit uncomfortable about it, right? Because there's always a certain amount of shame that you feel as a person because of how we've structured our society and how we see those things manifest itself in folks. And so it's just as difficult for the person who you're going to be talking to for the first time around this as it is for you to be able to go about doing that. So that's what I have found anyways, and that's what other experts with lived experience sort of conveyed in their conversations too, making it culturally appropriate, those sorts of things, and knowing a little bit about that you're allowed to make mistakes too, right? And we learn from mistakes. Mistakes are fine as long as we learn from them.
Yeah, I guess I would add to that too, that, in geriatrics, we have the 5 M's, and the 5th M is matters most, and that's matters most to the client. And what matters most to the client might be different from what you think should matter most for them. But the way to build a therapeutic relationship, and also recognize their autonomy and their right to make their own decisions, is to support what matters most to them. And then, as you go, maybe you can also work on some of, the pertinent medical things that might be coming up. I've certainly seen in my practice, I might be concerned about somebody's diabetes, but they might be worried about getting evicted. And getting evicted from your home of 20 years is, well, I haven't seen anybody who doesn't make that their priority. Let's just say that.
Yeah, I think those are really good points, Allison, that you can find common ground and work from there. And so often, it can be just one thing. Let's start with one thing and let's move forward after that once we get that sorted out for folks, right? And then that will add to the relationship that you're building, right? And you're not always going to have good outcomes, especially when it comes to housing. We know how critical the shortages are, and in the near future, it's not going to change much, and what happens later may not change much either. And so, but there are ways to still support people through that process and getting them connected to the proper resources. Sometimes that'll take some of the mental stress away that they are facing at the time, so that it's more shared stress than is really important also. But I like the idea of developing a list and then picking one and going after that first to see how far you can help with that.
Yeah, exactly. And there are some really big systemic issues, inherent in our system that, we're not going to be able to fix everything. I certainly, as a nurse, don't consider myself any kind of expert on eviction, but that's why we also have the broader community as part of our social prescribing team. It's not just us, we have a whole community with resources that we can use.
Yeah, that's a good point again, is you're not alone in this. You have colleagues, you may have, even if you have a smaller staff to be able to work with, they have connections with other people, and taking advantage of those resources and those connections will help to move the things forward that really are needed to be looked at.
Yeah, and I would say further, it helps you as the provider to advocate for your client. For example, for some of my clients that don't have stable housing, they've had to have, different kinds of day surgeries and things like that. And so knowing what their housing situation is or lack of housing, I've been able to advocate for them that they stay and recover overnight in the hospital because, things like that, where, that there might be a deficit somewhere else. So you see if you can add something down the road. Doesn't fix the actual problem, but supports kind of the recovery process along the way.
Yeah, you get better outcomes from being able to provide that for folks also, that have had surgery and need to have an extra day in the hospital, even though sometimes I'm sure that there's a lot of buttons you have to push to get that done, and patients don't see that and don't understand, right? Because we try to get people in and out of these institutions as quick as possible nowadays. Good.
Thank you both so much for those reflections. So I'm going to pass it off to Ellen to start us on to our next theme this morning.
Thank you, Taylor, and thanks, Allison and Mike, for that really interesting discussion. Yes, we're going to move on to the follow-up and follow-through portion of the morning. And I just wanted to, at this point, share a few reflections of my own around some of the important themes in follow-up and follow-through. One of the most important themes that came up in our discussions with Allison and Mike and others on our topic expert group was around the distinguishing between follow-up and follow-through. Following up is a very basic requirement in social prescribing, and it's equally as important as follow-up in any kind of clinical concern that a patient may have. The follow-up may involve a number of appointments to check in and see how the social prescription worked, and if not, set up another referral. And following through demonstrates a long-term commitment to the patient and should be the standard of care. So we felt that was a very important distinction to make in the tool. The next theme is taking the time to understand the emotional impact of the social prescription on the patient. In the follow-up, it's important to build time in to acknowledge and discuss how the social prescription worked, not just on a physical or practical level, but on an emotional level as well. It's important to find out how it fit into and improve the lives of the patient, but also their families and their friends as well. It goes beyond the actual patient themselves. Persons with lived experience who we consulted felt very strongly that it's important for their provider to listen to their social stories and to know that they cared for their emotional health as well. And the third theme that actually Allison and Mike did touch on already is around knowing as healthcare providers when there may not be an easy answer or solution for the patient. And this is a difficult thing to acknowledge. Serious issues such as housing and food insecurity that Allison and Mike touched on may be a lot harder to solve, and may require outreach that goes far beyond a regular social prescription or appointment. A warm handoff to a program is relatively easy to facilitate, while assisting a patient with housing, as Allison mentioned, can be extremely difficult. So in the tool, we have a small section on just allowing yourself as a provider to know when you may not be able to solve all of the issues that come before you. So on that note, I'd like to move on to the reflections portion of follow-up and follow-through. And I'd like to just ask Allison and Mike to speak to some questions and approaches that work best in follow-up and follow-through. Mike, maybe you can reflect on some of the questions that work best for you when you have a follow-up appointment. And Allison, what are some of the approaches that you use in follow-up and follow-through? Thank you.
Thanks. Yeah, so the following up and the following through are really quite important, and I think you have pointed that out, and people will feel that it's really important for people with lived experience, because often when we are bounced about through different organizations and agencies for different services, sometimes we feel that we are just another person in the line, right? And so people need to feel empathy. They need to feel kindness that we all should be using in our practices when we're dealing with people, whether we're medical background or if we are, just a lay person or working with communities that are marginalized often. And it's easy to forget about kindness and how important that is for somebody. And so when we sort of reflect on what follow through means, is in asking those questions and seeing that it's important from the primary care practice that they would follow through on it and ask you to be able to talk about that, starts to again build that relationship of trust that is so important when it comes to social prescribing, but also very important to the overall health of that person. And I think that, about you can't teach people how to be kind. It's something I think you're sort of born with, or empathy also, right? So it's important that people concentrate on building some of those skills, which take time to learn, right? And it'll make a big difference when you are actually starting to do some social prescribing for folks in your practice. I'll just pass it over to Allison.
Thanks, Mike. Those are great points. So when you asked the question about follow-up and follow-through, I was just thinking about a quote from one of the physicians I work with. Her name's Dr. Allison Eyre. She always says, "Nothing for me without me," as it relates to the client. Don't decide to do something for me without me, basically, is the idea. So with the follow through, just as with, describing, figuring out what you want to do, it's a co-creating process. So in geriatric outreach, often the clients need support. There's, barriers that you would think wouldn't even be barriers. Lots of clients don't have phones, don't have internet. So contacting these clients is quite tricky. A lot of them are housebound, so most people don't get to see them. So a lot of it, initially, I would say, as part of the follow through, it's figuring out who the client has in their corner, which I mean to say, who helps them, who can they count on. Maybe it's the next door neighbor whose phone they borrow all the time. Maybe that's the phone number we're putting down if we're doing a referral for food bank delivery for the client with food insecurity problems. So kind of having that as part of the follow through is really figuring out who's in the client's corner and who can support them with the social prescribing plan other than yourself. So that's one thing. And then I find a warm handover, making the call with the client, having whoever's speaking on speakerphone, or supporting them with the all the automated phone things now, push 1 for this, push 7 for that. For clients who have hearing difficulties, this is nearly impossible, just that barrier. So kind of getting through that kind of red tape with the client could be helpful, or having somebody on the team who can do that. And then I know Michael mentioned mistakes, but I tend to not think of them as mistakes when we inquire. Did you ever hear from the Good Companions, or this or that seniors center? Did you ever get a phone call from them? And then hearing what the client has to say. Sometimes the client doesn't remember. Their phone was broken. So then it's, okay, well, let's call them again and let them know your phone's working. So if it doesn't work out, just have that curiosity, non-judgment, oh, that's so interesting. Why didn't it work? I wonder what we can tweak. Or, oh, actually, you feel like you just don't have time for that because you've got PSWs coming in twice a day, or I don't know what there. So sometimes when things don't work out, it helps you zoom in, narrow in on a better approach that might be more effective for the client.
Yeah, those are great points. And I just wanted to come back to barriers that people often face, and how sometimes they're not recognized until we've lost somebody in the system, right? And the phones is a really good example. I have these tremors in my hand, and they ask you to push the button on your phone, right? And so sometimes it can take quite a long time to push the right button. And so all things considered is important, And the other thing that we didn't really touch on is trauma-informed care also, right, Allison? It's really important to remember that many of these folks that have trauma as a background, and that can make things more complicated, but always being aware that the trauma is most likely present in people's lives, especially those that have experienced certain things. There's going to be some trauma there, and your approach around that may be a little different also about how you end up handling. I noticed people were having trouble hearing. Can everybody hear all right now? Or are we still being too quiet talking? Okay, I'm taking that as people can hear us. I didn't see anything in the chat, so that's good. Also around organizations, there are some organizations that are much better than other organizations. I'm not going to go into details, but you'll find that some are better than others and at doing certain things, right? And those often because there are barriers in place. Like recently, I went to a low-cost dental clinic here in Toronto, and believe me, the very first start of it was like filling out 5 pages of paperwork, right? And that can be quite. Nobody asked if I needed any help or anything. That can be quite daunting. You know, trying to remember what your medications are, what your dosages are, past history that needs to be included in those forms, you know, people need sometimes a little bit of assistance when they're doing that, and they won't always ask for it because they are a bit worried, right? You know, some people still in our society don't have good writing skills. They don't have good reading skills. That's not something to be shameful of. It's a reflection on the systems that we've had in place that have not served people in a good way. And so it comes back to being non-judgmental, but finding ways to work with organizations. And organizations, I can tell you, are, you know, they have their hands filled because there is so much going on that they have to provide, and they don't often receive the funding, which means that they aren't able to have the proper staffing. So it's just not within the medical community where we're feeling the pinch of our time and our resources. That's also happening in the nonprofit sector for organizations also, and that, you know, people when they go into a place and they have to queue, it's, you know, it's easy just to slip out the door sometimes than it is to queue up, depending on what you have to do. And I think that, you know, sending people back and forth to different places can sometimes be a sign that they're running into difficulties in accessing it and may need some more support, maybe somebody going with them for 1 or 2 times and getting them familiar with how the system sort of works.
Absolutely. Yeah, that makes me think of another person who was on our panel with life experience, and she was describing how when she had to go see her rheumatologist, she had to take 3 different buses across town, and with her chronic pain, that was really difficult, but that was the option she had given her financial where she was at financially. So, you know, knowing some of those things can be really important for how we provide care too. I mean, I think many clinicians, knowing about 3 bus rides across town, might think to offer a virtual if they're just sharing results or things like that.
Absolutely, and we see that a lot because often people, you know, I'm thinking of single moms having to trot 2 or 3 kids across the city to make an appointment for housing or for a medical appointment or to get food at the food bank. You know, if they don't have access to childcare or a neighbor or a family member that is supporting them, the outcomes then are pretty dismal often, right? They just go without, and going without shouldn't be an option for folks. You know, we can't be calling ourselves a caring and healthy society when these things continue to manifest themselves in so many different areas of people's lives. And that's why I think this presentation today and the introduction to the social prescribing is so important because it's recognizing that the connections that are there around people's lived lives versus the health consequences that often come with that.
That's right, Mike. I've seen with geriatric clients as well, people love to prescribe or order diagnostics or, come on out for chair exercises, which is fine, but they don't recognize the energy output that it requires for somebody with, sensory issues with decreased mobility. I recall one client who told me he went to get a chest x-ray. This was a gentleman in his 90s with his walker. He ended up taking the bus, waiting at a diagnostic imaging place for about 4 hours, and then busing back. And he told me he slept for 2 days because he was so exhausted from, trying to, follow through on what his provider wanted him to do. So I would just say with follow through, really find out how often your client is actually getting out of the house, if they have mobility challenges, because maybe some social prescribing that might be the most effective would be social prescribing they can access from their house versus going out to.
Excellent.
Allison and Mike, I'm just going to jump in and just say thank you so much for the incredible concrete examples that I think are just fantastic takeaways for the group today. So thank you so much for that really amazing conversation. And I think we're going to proceed to the next section of the presentation, which is actually the Q&A. And at this point, we welcome folks to chime in. If you're more comfortable putting something in the chat, we'll be monitoring that. And we're happy to take any questions that you may have at this moment.
I think I can answer one in the chat. One question I often get from our clinicians is what is different from referrals? Super good question. I just lost it. So basically, I think the difference is that you're being intentional about it and you're well, for us, we're putting it in our electronic medical record when we've made the referral, and then we're documenting the follow-up as well. These days, post-COVID, it kind of feels like when you send a referral, it's like gone off into limbo land because the wait lists are so long, be it with social prescribing or, a medical referral to a specialist. So, yeah, I guess with a social prescription, you are kind of including it as part of the standard of care for clients, and doing the follow through afterwards, and kind of, if it's hasn't worked out, narrowing the lens to look at what would be the next option. I don't know if you want to add anything, Mike.
Just quickly, that social prescribing in itself, is often it is a preventive measure, but also it is a prescription to the impacts on people's health that are happening in this time, right? And we know that a lot of these issues do impact people's health in a very negative way, whether it is today. It could be 20 years down the line that it rears its ugly head in some, disease that, the people who experience these things are often more prone to. And so part of social prescribing to me is recognizing that the people's health is at risk by not having a lens of social prescribing as clinicians, recognizing the dangers that people face. As I said earlier, often people don't realize the dangers that they are facing with health consequences that will rear its ugly head later. Like for me, it was probably, I have so many health things wrong with me now, and they aren't just sort of genetic, or they are environmental and situational diseases that have developed because of the process that I went through that was sort of dictated to me and caused damage, right? And recognizing that those are more likely to happen to people in these communities than to the general public is critical around the importance of social prescribing and understanding the overall health and well-being of folks who we are serving.
I just wanted to chime in. We do have a couple of really great questions in the chat, and I'd love to try to get to at least a couple of them. Maddie is asking, how are you tracking in the EMR? And what barriers have you encountered with doing this type of tracking in an EMR? Allison, can you speak to that?
I am not that up to date on how people track things in the chart. At our community health center, we do have like IT specialists, and I know they do it. I just have no idea how. I know recently we implemented some of the new forms from the Alliance for Social Prescribing and got them formatted into our EMR. And then, so just to follow up on some of the other questions I've seen. So a social issue might be identified by a clinician, and then this would be written into the form in the EMR. And then the form would then somehow go to the health promotion team, and they would do a follow-up, and then the clinician could also see in the chart what had happened. And a check-in was decided like a month after the social prescription was done. I think it was like a month, to see how it was going, if the client needed any support, things like that. So I don't know if that's helpful. So I don't know how people track things.
Oh, that's okay. Thank you for that insight. Another quick question we have is, would you have any tips on how to engage an already overloaded physician in starting social prescribing?
Sure, yeah. I would say, well, we had an amazing health promoter who brought it to us a few years back, and her spin that she put on it was, hey guys, this is something you're already doing. So let's just show in the chart that we're doing it. Let's have a way of communicating it, because you're probably already doing it to a certain extent. And then they put like a laminated card in each of the exam rooms, like one of those ones you can write on with a whiteboard marker, laminated. And it was like, are you feeling lonely? Are you feeling disconnected? Are you, and a few different things like that. And then the physician, it kind of triggered the clinician or physician or nurse practitioner, whoever was with the client, to think about that, having something, close to the computer, the workstation, and then having just a really, later, the simple simple form in the electronic medical record where you really just, click something on, write a little note about any barriers, doesn't have a phone. So things like that.
I think we actually have time for just one more question. Thank you so much for adding to our chat today, everyone. Allison, I see that this is one that would be pertinent to you. Kimberly writes, although I understand the importance of doing home visits, this is not something we do often due to safety concerns. How do you ensure your safety during a home visit?
That's a wonderful question. Hold on. Just getting things popping up on my screen. There we go. So we get a referral form where it's possible that people can highlight safety concerns on the referral form itself. Typically, before I see anybody, I give them a call. We have a bit of a chat. And I find out sort of who's in their life and see if they might also be able to be present when I do my intake. I always have a cell phone on me. I keep myself between the door and the patient. And often for new intakes, I bring along the team social worker. So I'm often going in with a second on the first visit. And then after that, it's kind of like, okay. But always have the phone on me. Never sit closer to the door as well.
Right. Well, thank you so much, Allison and Mike, for responding to the questions, and thanks everyone for so many of them. And I think we are actually getting close to the end of our presentation today. And the final thing that we'd like to do is, from Allison and Mike, we'd like sort of a call to action, a one-sentence, concise closing thought on what you'd like to share with our participants today around social prescribing. Mike, would you like to go first?
Sure, mine is quite simple and short. Is social prescribing can be the bridge that will build upon better health for all your clients.
Allison. Oh, you're on mute, Allison.
I said that was very concise, Mike. I don't know if I can be quite that concise. I guess I would just say that in the clients we see, there's an intersectionality of poverty and class and social isolation and trauma, discrimination, social inequities. We like to try to see people through our medical lens, but people are made up of a whole slew of experiences. And I think we can deliver more effective care when we consider the social determinants of health related to our clients. So I guess my simple message would be, you're probably already doing this. It's just making it a bit more intentional. And there's beautiful forms that have been developed, and it really does mean something to a client when you hold space and hear what's happening, what matters most to them, and then when you ask them how it went. Like, some people are stunned when I ask them how it went, because they just didn't expect that support would still be there. So I think it's a valuable part of practicing caring for clients. That's all I have to say about that.
Beautiful message. Thank you. We're about to conclude the presentation today. On behalf of Taylor and at CEP, we'd like to thank Allison and Mike for participating both on our topic expert group and today. Just so valuable. So thank you so much. And I also want to remind you of the social prescribing resource, which has just launched on the CEP website. We've provided the URL there for you, and also want to remind you that it's something that you can print out, you can share it with colleagues, you can put copies in your break room, pass them around at meetings. Please just spread it around, and would love to hear your feedback. So thanks again, and have a great day.